Hey everyone, this is the Nips and Sips podcast show. Feature me, I'm Dr. Jeremy Boyd, and my usual partner in crime over there, Dr. Brandon Cruz. We're going to pick up where we left off last episode, where we talked about the examination and evaluation of the overhead throwing athlete, or really just overhead athletes altogether. And we're going to go roll right into treatment to kind of help all our clinicians around, kind of see where we're coming from, maybe some unique different ideas, and kind of get our throwers back in the game quicker. But before I get into it, Brandon, how's it going?
Going well over here, Jared. Excited to talk about the second half of, kind of the throwers paradox or the overhead athlete in general. Yeah, that's kind of it. What do you got on drink today? On tap?
Yeah. So going off my beer of the month club. This is a smash and grab IPA. Try and get theme here. It's like maybe when you do some throwing or athletes, you may smash some things or tell them to smash some lacrosse balls into them. So that was a theme there. It's from Legal Draft, Arlington, Texas, which I know baseball is pretty big down there. And it's just an IPA, and I'll give my rating soon. This is beard glass I just got in Connecticut this weekend with some friends. Nice little glass. But what about you, Brandon? I'll give the rating as soon as I'm done with this.
That's an IPA, you said? It looks like it'd be a sour beer.
It's IPA, yeah. I mean, they got the colors which looks limey and everything like that, but it's just I guess it's just IPA. It's a single hop IPA, so it's a smash style, and let's see, strong backbone of malt balances well with notes from unique hops. You got the loot. So I guess that's their tagline. So I'll my first beer that I made was a smash IPA, so this is interesting.
Very nice, good pour.
Yeah, look at that. Better than the return of Nips and Sips. That one went everywhere. That sucked. But definitely can smell the hops on this puppy. Oh, not bad. Not too well, I'll say it's like too IPA. When I have too many IPAs, it's just like they all taste the same to me. A little bit lighter. Not bad. Nothing like mind-blowing or anything like that. A little bit of an aftertaste afterwards. I'm gonna give it a 7 flat.
All right.
7. Not bad.
Not great, not bad. Around the middle.
Yeah, right there. What about you, Brandon?
All right, I got the big guns today here.
Oh baby, is that tequila?
Yeah, tequila Herradura. This is from a former intern, actually from your alma mater, Franklin. He actually got it engraved as well.
Oh shit!
It says to Dr. Cruz, thanks for all your help, Frank. So I love the bottle. The bottle's
that's badass.
Awesome. Yeah, it's top flight right here. I'm saving this bottle, and then we're gonna fill it up with Costco tequila when I'm done. So I haven't had it. I'm opening it for the first time. So Frank, if you're listening, this one's to you, bud.
Yo.
He was a great student. Really, he showed his evolution from his first couple weeks all the way to when he finished, and he's going to be a great therapist. I'll talk to him now. So excited for his future. But thanks for the tequila here. Let's see what we got. Let me put that down right there.
There we go.
Box here. Oh, that's smooth. That's a good one. It's a añejo as well.
Oh,
that's really good actually.
Oh man, he's double sipping. This is gonna be a good episode.
Yeah, that's smooth, man. That's real smooth. All right, so that's my drink for today.
All right, well, cheers to that.
Cheers, man.
Oh.
All right, so you wanna take us out there, Jer, on overhead athlete / throwing athlete worker, that kind of overhead weightlifter even. And I don't want to be too biased to just the thrower. I think we get too hung up sometimes in just boxing and compartmentalizing these types of people or athletes. But, for there is some specificity to it, but there is some generalization to these types of people that are patients that we should be treating and looking at. We talked about, evaluation. What kind of things are you doing for treatment? What are you looking for without trying to be too cookie cutter or general there?
Yeah. Based off of what we talked about or kind of alluded to the previous episode, I'm sure everybody should listen in, is, I like to look at it not purely from where the pain is. We always mention here that, pain is a liar. And I think that's especially true when it comes to typically shoulder and elbow pain, or the classic, biceps region, forearm pains. I think that's even more prevalent, where those areas typically aren't the pain generators. So I like to try and look at things from, the whole body. But definitely, as we mentioned before in the previous episodes, I try and look at things proximally now. I think I find more value in treating things, again, from the proximal source, more of the spine, or shoulders overhead, like scapula. I know, we always kind of talk about our evolution as therapists, me previously and that sort of stuff. When I got a thrower, or, I see a lot of Olympic weightlifters and those sort of things, a lot of the, treatment was guided towards that shoulder. A lot of, joint mobs, glenohumeral joint mobs. I'd spend a lot of time there, do a lot of cuff strengthening, really kind of hope for the best. I wasn't hoping for the best, still got some good results. But, how long it took, or how many of those shitty things were going well, and kind of they come back in and they'd be like, yeah, went back into training, kind of got pissed off again. Sort of moments that those tear me up every time. I hate those when they come in and they just say that. I'm like, son of a bitch, what, why did they do this? And it's probably treating almost too locally. So yeah, picking back off of the examination, I'll, start my examination with the cervical or the cervical thoracic spine. And a lot of what I do there, just from a, neuromodulation or modulation of pain perspective, I'll do some techniques there often the times, usually on the painful side. If you're doing a good job of examining the cervical and thoracic spine, even further down into T-spine, I think I used to stop down at like, T3, T4. You'll find a lot of pain in those, right in the UPAs. So that's a unilateral posterior to anterior mobilization of the transverse process. So really kind of diving into doing some of that. I think manipulations just to kind of, calm things down. I had a discussion with a student, is purely the student was only treating things if they found an impairment or if it reproduced things. And I think I went down that route. I think the idea of we should only treat impairments versus, asymmetries, versus just having the idea, can it make it better? Is it okay to treat things that don't necessarily have a objective impairment? And I find in some value with that of, what does it do to their pain? So yeah, they may have great rotation, cervical side to side, full range of motion, but can I do a technique and can that help their pain when they go up and overhead? Can that give them the confidence it's like, oh crap, he did a cervical technique, thoracic technique, or he had me do some self mobilizations and now I can get overhead without some pain. Like, okay, great. There may not have been a particular impairment, but it certainly helped. So that's kind of where I'm starting to go towards my evolution, starting to treat things and just looking, what can I do? What additive effects can I do to really just change their pain and then get them going? Especially for these more non-specific type of pains versus obviously things are a little bit different when we have a thrower that has a labral tear and it's post-op, or a UCL tear and it's post-op. I'll still do these things to help out their pain. But obviously it's a little bit of a different process. You get the healing of those tissues and everything like that. So, from there, start to kind of transition towards, checking out nerve mobility and maybe doing some nerve techniques as well that we mentioned on the show. And then I think there's a lot of value if you look at a lot of the research of, elbows, UCL injuries, labral injuries. A lot goes into the scapula versus purely, going into, rotator cuff. I know a lot of us, you look at a lot of your thoracic tendon and that sort of stuff has some components of it. But a lot, I think I did, especially early on, was like, oh, they have a difficulty of external rotation. Let's just keep doing a ton of banded ERs and do that for days. So, that's kind of, I guess, the gist of how things are going. Probably go more into depth, but realize that was probably taking a little bit long. But Brandon, how about you? Let's move on to you while I get a sip.
Oh, good, man. You said something about and I guess a student or an intern you were working with that was treating too locally, or even which is good, looking at impairment based, right? Yeah. And only treating if it recreated their symptoms, which is good in the beginning. That's a good evolution, especially for someone that young to even have that presence of mind. As we've evolved, and it's funny because we've had this conversation is coming up now in our podcast. It came up earlier this week on our mentorship platform, and I had a conversation with the fellow I'm training past couple of weeks, something called comparable sign or comparable sign in an appropriate structure, right? Meaning that there is a structure relevant to the presentation, but it does not reproduce the said symptom of that patient, but it does recreate some type of pain. And I think oftentimes that gets overlooked, especially with joint stuff or even neurodynamics. It's like, okay, there's an impairment, there's something going on, but it doesn't recreate that person's pain. So we kind of, dismiss it instead of paying, more attention to it, especially those patients that things aren't really adding up. And they have, like you said, diagnosis of biceps tendon or some type of sprain, and you're probably doing soft tissue to it, right? Because we're thinking soft, a sprain of the soft of the muscle. We need to do like a massage or something like that. So, yeah, smashing. What would Sammy's or something, right?
Sammy's
smashing with the ball, right? So a lot of I've had baseball players and lacrosse, not lacrosse, CrossFitters using lacrosse ball. Always on their upper trap, always on the rhomboid, trying to just mash that stuff out. And you do a median nerve glide or ulnar nerve glide, and they're tight, but it doesn't reproduce their pain per se. Or you do a mobilization and it doesn't reproduce their pain, but it reproduces some type of wonkiness or achiness there. You also talked about, you would go down a T4, right? And that's good, right? I've done this too. We've all kind of done it. Regional independence. Oh, it's shoulder. I checked out the neck. I checked out the T-spine. Great. But I've noticed going further down that T-spine is huge, especially into that lower and middle section, T6, 7, 8, even 10. That's where you get some stuff, because if they're not, or if they have too much lumbar extension or TL junction extension or lower thoracic extension, that's where they're kind of getting hit. We don't have videos of a bunch of exercises to show people what we do and how we treat, but general concepts we could try and go over. I think as therapists we need to not, and we talked about we talked about Adam Minkins and Chad Cook, and these left ring and right ringed, and manual therapy and exercise. We need to be able to put these together. And Greg Cook was very paramount, at least in the late 2000s or early 2010s with the movement analysis. And we need to begin to kind of look at that, like whatever athlete you get, we got to get movement fundamentals first. We need to train them, go back to the basics, train them at whatever we need to get them to just move well. Then we need that functional performance or that strengthening before we go to skill. I think too often we want that tricky or trendy new exercise that's going to really mimic what they're doing. And a lot of times it's not that we need. We need to go back to the basics and clean some stuff up whether it's using manual therapy followed by some self-mobilizations, followed by some, activation or motor control exercises. And then you can build up to the fun stuff afterwards. And if you're dealing with a high level athlete, chances are they can do the skill stuff fine.
Mm-hmm.
They're lacking, some of the first floor, basement, first floor, second floor type stuff that is causing their pitching to be wonky, not the fact that they're a bad pitcher. If you have somebody who's not the world's greatest athlete, chances are you don't need to make them a better, you don't need to work on throwing, you need to work on making them a better athlete. And that starts from the bottom, making them move better. I have some things here, some articles by Ewell, HUL. We have Reynolds, we have Blackburn's, articles that came out in the early 2000s that really look at muscle activation. Granted, there's flaws in them, but there's different, they give different examples or different exercises that have better activation of not only the rotator cuff muscles, but the periscapular muscles. And even, switching up and doing things in weight bearing, doing T's in a quadruped position. So there's some closed chain approximation going on there. Or you're doing it in a plank position. You have your feet up in a box in a plank position. So now there's more weight on there. Treating, we talked about last time, maybe looking at balance or looking regionally. And throwers, maybe they have, crappy, pelvic control and their hips just shooting out and Trendelenburg, and they're kind of falling out to the side. It's causing the arm to kind of flare out. And then their ball is probably either flare out, to the right if they're right-handed, or they're trying to overcompensate and break that, wrist faster, and they're coming across their body, and that ball is shooting to the left a little bit. So, being able to understand these things, and again, our job, is not necessarily to do the sport specific stuff, but get them ready to do the sport specific stuff. And then, you're passing them off to their coach or, whoever they're working with there. Another thing that was good, and I used to use a lot more, I don't use as much now, but it definitely helped, clean up my thinking and at least give me some type of standard when I was rehabbing these athletes, was the upper extremity wide balance test. All right. So it's basically the FMS for the upper body, which was good. It gave me just some ways to objectify what I was doing, to help see an athlete's progression, to help see their strength, their coordination, their endurance, and things like that. So, if you haven't looked into that, guys, definitely play around with the upper extremity wide balance test. Again, are there some limitations? Yeah, but at least it gives you, a box or some type of framework to begin to look into, to help the evolution of your thought process and treatment.
Yeah. I also like to use the upper extremity, like close kinetic chain test. It's pretty much you put 2 strips of tape about shoulder widths apart, and they have to go with one hand tap to another. Go tap one tape, tap the other tape in a plank position. That's really good. There's some normative values for that, for actually throwing athletes, and then I think it goes into position specific, what like pitchers should get what versus more of your field players. And then the one arm shot put test. I think that's a good one for like overall power development and that sort of stuff. And how much they should be better than obviously they're not involved. So yeah, those are all great tests. And that's the main thing is being able to, I always take value of what the patient says, but also make sure objectively they're improving. Because most patients will constantly say, you ask them how you doing. Oh, yeah, I feel a little bit better. It's like a little bit better. I always tell my students that means probably about neutral. They see you trying hard, so they're always going to
feel bad.
Yeah, exactly. Especially when you're like experimenting with things and that sort of stuff. So, getting your good objective measurements. Also, especially for those individuals that almost need to see what Toko always says, proof in the pudding. So if you're showing them, oh, well, you were here and now you're here, oh, they start to say, oh, I guess I am improving, especially for those chronic pain patients that are just kind of used to their pain and their levels of pain and that sort of stuff. But yeah, Brian, you made up some good points that I kind of want to talk about. I actually want to branch back into something about neural dynamics and some of the other conversations, and we were talking about, just doing something to see if it makes a difference. Like normative values of like neural dynamics, the classic thing of that was kind of see or kind of blew off with certain things, especially in throwers who have to, get all the way back into their pitch beyond the human, we're taught 90 degrees is normal for a normal human being of external rotation at 90 degrees of abduction. The pitcher is going all the way back, so that they're pretty much, they're flat, they're 180 degrees. What is like, that normative value? Like a lot of times I would just go and say, hey, I tested out, and it's like, okay, they get to a point and they're like, oh, nothing reproduced. And it's I guess didn't cause any pain of any sorts. And it seems pretty even both sides. Is that okay? Or is it, is there something that we should expect with our neural dynamics? Let's say, just like the median nerve, which I demonstrated, are we expected to get all the way to the end range? Is that something we should shoot for? Or do we have this pure mindset of we just want symmetry both sides and that's good enough and keep blowing through? So this conversation I had with a clinician and that sort of stuff is, I think, we have normative values of like knees and hips and range of motions and somewhat of strength. Why not have neural dynamics? Why are we just okay with symmetry versus maybe more mobility? Kind of just a thought process and that sort of stuff.
I mean, if you look at the what is the as at least range of motion wise, right, is lacking 10 degrees of elbow extension.
Yeah.
I'm looking at each joint. I'm looking at, what the neck does. And it may not be a pure side bend. It may be a little shrug, but they're asymptomatic, right? I feel nothing, but I feel their shoulder or their upper trap just kind of shoot up. So I'm looking at that. I'm looking at the wrist as well. I'm looking to see if maybe the shoulder kind of shoots forward. Can we measure these things? Probably not. And I guess it's a feel thing. And if you don't know what to feel or what to look for, you're going to say it sucks or it's not accurate. Granted, yeah, but there is a gray area, and that's where we operate sometimes, and we have to be okay in operating there. But I'm looking, especially a thrower. I mean, forget 100, 110. I want them here, and I'm loading and I'm tractioning down. I have them side bent. Like I should be able to load that up. And I was actually having a conversation with, Anthony, the fellow I'm training yesterday, and I'm going to make an email about this actually. So it's funny. It came up again today because he had and we've had, several conversations about neurodynamics and, how I use them, and I use them more. And I think they should be more integrated in not only our treatment, but evaluation. And we're talking about, we've talked about our evaluation, and I'm kind of a little bit more free flowing in mine. He's more linear with his, which is fine. But what he said is he's like, I had my third CrossFit athlete, and they were all jammed up and they had some anterior shoulder pain, and, he screened out the neck. And then the next thing he did, he's like, you know what, I'm just going to go look at neurodynamics right now. And he did it, and it cleared him up. And we were talking about kind of just like, his thought process and, how he felt finally, kind of comfortable to jump forward and with that sooner rather than later, instead of just waiting longer. Because I think part of, clinical decision-making is that pattern recognition. And yeah, you may have your linear thought process of things you need to check, but if hey, I've had X amount of overhead athletes, and this tends to be a problem area, move that to the front of the line instead of, making an eighth on your things to check. Let me just bump that up to, second or third and check that out. So, I definitely think neurodynamics is a big piece. I've definitely had, and if you think about the mechanics of, you got throwing like that, and they're just, especially if they're having pain, they're compensating, they're turning their head and pulling through here, tractioning all these muscles in that upper quarter region. You have, people snatching or jerking all this weight, head through the window is how they're coached, which if you look, just looks awful. Like, look what's happening through here. It's all being traction and stretched and just a ton of load there. And then, they get this like knife-like pain through their upper trap or their anterior delt, and they're just trying to mash it out and no real success. I want pliability within that nerve. I want to be able to go up to 110, 120 and add, my overpressure distally and proximally and crank on that, nervous system or whatever other structures are being handled there. And if they can't handle my 5, 10, 15, 20 pounds of overpressure, are they going to be able to handle all of the forces that are compressive forces when they're throwing a pitch or when they're snatching 200 some odd pounds? It's something to think about, or, a construction worker who has a, holding sheetrock up with one hand and drilling in with the other hand, or someone maybe who's using a jackhammer, all those forces that are going through the body at one time. Instead of just looking black and white at whatever structure. So I'm always, to answer your question, I know kind of went around in circles there.
That's great.
To answer your question, I'm always looking for pliability. And if they have no range of motion, limitations, the elbow, extra valgus, extra varus, just lacking extension, no, wrist fracture, nothing that's impeding joint range of motion, there shouldn't be, lack of motion there. At that point, we're not, not looking at symmetry. They need that pliability through that. And then a lot of times you work on that and then their muscles calm down and then you get more joint play. And then you can do some other things by addressing, the neurodynamic system first. So huge stuff. I think neurodynamics is definitely underlooked in this population, and muscle tightness and soft tissue and cupping and even dry needling is overused in this type of population. So, I look back, I think you had brought up one of Mike Reynolds' podcasts or something. And, I think they were talking about manipulation, and one of the guys on their staff, I think, uses manipulation a little bit more, but Mike Reynolds like, no, I just mainly do soft tissue. I find a lot of these players have more soft tissue strains and sprains. I'm not treating his patient population, but just kind of hearing that and seeing what I see, I think, using some more joint-based and neurodynamics might, lead to utilizing less soft tissue for these people, and better results or faster results too.
Yeah. I think a good thing to test out. I mean, again, I mentioned on show I was a big soft tissue guy before I came in, or when I came into the profession and everything like that. But the classic is, most people have either hypertonicity or trigger point, especially our overhead athletes, especially the CrossFitters, Olympic lifters, get into their traps and, levator, mid-scapular region. And before you start going to town on them, try some neurodynamics. And then again, it could be mid-scapular, something like that. And you think that's too far away, just try it. Take the 30 seconds to floss it 15, 20 times or whatever it may be, and then go and repalpate. I like to use sometimes, not as much as I used to, but using the pain pressure threshold algometer, and just, all right, get an objective measurement. It took 20 pounds or 20 newtons of force to piss off that trigger point, floss it 20 times away from the area and come back to it. And it's up to 60. All right, well, I didn't have to go and annihilate the person with my elbows or cupping and that sort of stuff. And it made a huge difference. So I agree that, I believe it's underutilized and that sort of stuff. And you got to think, I think a lot of what amps up the nervous system is obviously stress. We talk about that with like radiculopathies, fibromyalgia, all these sort of things, and high stress. And we think, you're stressed at work. We got the guy holding up sheetrock and having to take care of 4 kids, yada, yada, yada. But what about stress within the sport as well? The neuromuscular stressors of, snatching 200 pounds and holding it over your head so it doesn't crush your head in a brief, less than 3-second moment. It's very taxing to the system. So you gotta imagine that what it wreaks havoc on that nervous system. Same with, throwing a pitch at, 6,000 degrees of revolution. That's a ton of stress, physical stress on the nervous system. So more often than not, then so it may need some treatment towards that area. So that's something I see, those, especially those heavy lifters, high speed sports. I think the stress of just the sport themselves, ramps up the system. And, I like to kind of hit the joint first, which seems to have some neurophysiological effects, and then kind of get into the nerves. And then sometimes I'll combine them. I'm finding a lot of benefit of combining them both at the same time. We've talked about that. But I think you brought up some great points. And from an assessment perspective and from a treatment perspective, the classic, burpees hurt, or, if it's burpees or overhead push-ups or stands, we think, oh, it's, especially for the wrist, we think it's like, oh, it's purely, them pressing down on that. Think about that position, and that's that right there, fully, extended elbow, extended wrist, extended. That's, your median nerve tension position. A little different than the classic testing position, but it's just modified for that sport. So, it's definitely something to take a look at and treat. It takes, again, 20 seconds to floss it 10 to 20 times. So it doesn't hurt to test it out and see if it makes an impact. But Brandon, for other areas, you mentioned, what are some, I guess, common trends or anything like that, maybe even further down the chain, that you see as a problem that needs to be addressed? You talked about some things about, getting to the basics for a lot of these elite athletes, but anything you see, let's say, outside of the shoulder, thoracic, cervical, arm complex, anything that you commonly see between these athletes, and maybe something that they have issues with that need to be treated well in the care of a physical therapist?
Yeah, I will, but I want to say something. You mentioned trigger points, and that reminded me to our neurodynamics class, and in creating the neurodynamics course, there's something called AGS, right? Abnormal impulse generated sites, right? And this actually causes or contributes or leads to, in some way, shape, or form, or capacity, trigger points. Right. Trigger points are defined as taut band, and there's physiological abnormalities. Typically, there's that environment's more acidic. There's more gags in that area, a bunch of other mechanical, chemical, and thermal stimuli, or, that are contributing to it. But, what's making up or causing those trigger points is those AGs, right? And that is basically nerve generated impulses caused by damage to the nerve. And it doesn't have to be severe damage, just micro damage, or disease causing some type of demyelination, throughout that nerve. And that area is trying to kind of regenerate. And that's what's causing what they call that dysynthetic pain, or those trigger points in that area. Right. So, how do we treat the nerve? It's nerve flossing, neurodynamics. That's, the only thing we can do, but that's going to, add mobility to it. It's going to add oxygen to it. It's going to add movement to it, and other biochemicals to help heal that area and clean that area up. So, just to put perspective, if you're out there in the camp, treating trigger points, well, ask yourself, what are trigger points? And it actually is coming from, ascending and descending from that dorsal ganglion in that nerve, that peripheral nerve. But to answer your question, I'd say the biggest thing I see, especially in the high school, college athlete, even actually, the CrossFitter, is, poor glute strength, core strength, motor control, if you want to live with that. And throwers, it's single leg balance. It's being able to stand on one leg and not only balance there, but now generate force in a concentric, isometric, and then eccentric, portion. So I'm looking a lot at the single leg aspect, the half kneeling aspect, or a split stance aspect, and seeing where that patient is. And a lot of times that knee's flaring out, and to, a combined external abduction.
Mm.
It could be that pelvis is kicking out to the right and there's causing for more internal rotation / valgus. So I look a lot more into that core control, core region. And by core, I don't mean abs. I don't mean six pack. I mean, obliques, pelvis, glutes, adductors, where that force is being transmitted, absorbed in and transmitted from the lower extremity to the upper extremity. And that's what our pelvis is for, or SIJ region even as well. I think we talked about it. It's to be able to absorb those forces from the lower extremity and transmit them to the upper extremity or vice versa. So I spend a lot more time with my athletes in a half kneeling position, chops and lifts, single leg with a knee drive, maybe adding some type of perturbation there. But I need them to have good isometric control at that knee and femur while everything else is kind of moving. So that's what I'm looking at a lot.
Great. Yeah, no, I think that's huge. I think it's missed a lot in the college and high school strength and conditioning. It's typically let's just put some weights on the bar and get them stronger, which certain things like the deadlift is great core exercises, but doesn't exactly link up to their sport as well. As Brandon mentioning, single leg stance, the pitcher needs to be able to balance on their stride leg. It needs to balance on their stance leg as well. I like to look at control of things like, can they even take it another step is can they balance on one leg and lift their knee to their chest? And you'd be amazed that they can't do that just in the clinic setting. Can you lift your knee to your chest? And they don't have that control. But if you look at take a Google search of all the amazing pictures that you've ever can think of, and their knee is almost at their throat when they're doing that, but a lot of them can't. So is it more often than not, especially at the high school, college level, most athletes are fairly mobile at that point. They're not advanced aged athletes of any sorts. They should have the mobility for the most part. Sometimes they don't, and then we have to go clear some things out, but they don't have the adequate control for that sort of stuff. So doing things in those positions, as Brandon said, half kneeling, I think there's a lot of value into that. Looking into things into the ankle as well, either from a mobility standpoint, especially obviously dorsiflexion, but also from a control as well. I feel like a lot of training programs are obviously, all right, shoulder care is great, doing some things, address the scapula and the cuff muscles. It's important, but if the whole kinetic chain is messed up due to poor core and glute control or strength, you're not going to get very far. They're still going to develop injuries and all those sort of problems. So it's time to look at the whole kinetic chain. So there are some great strength coaches that do that, and I love them, and those are the ones I refer to. But a lot of times by the time they're injured in the clinic, it's time to educate the athlete. Hey, we need to do all these sort of things. You need to be maybe take it accountable for yourself to make sure you're getting these sort of things, especially from a balance control standpoint. That's most strength coaches, they want to add some weight, build up some resilience and that sort of stuff. The control sort of stuff, that a lot of that can be done at the home front. So yeah, I totally agree there, Bren.
Awesome. Anything else that you see or like to do with these overhead athletes, and maybe either maybe when you post this, you can put some videos. I know you're very good at recording a lot of your patients and athletes, doing all sorts of stuff outside the box things. So I don't know if you want to do that, or if there's just any kind of last kind of parting, interventions to really impart on these people, or anything that you see that kind of should just drive home that message.
Yeah, and the what we kind of talked about and what you did a great job explaining in the first episode of this was, hammer home education. It's still surprising how many, I got just turned 15, but he throw 80 miles per hour. He's pretty, steadily. how many people don't quite understand like the pitch count and those sort of things. So a lot of it, you can't trust, everybody else that supports the athlete per se. Sometimes you need to be able to, educate them like, listen, you got injured now, and maybe it wasn't so bad or whatever. Maybe it was bad. You still have a long career. Is throw in that education, like, listen, you need to take upon yourself of respecting what your body can handle and the demands and pitch counts and overall, or CrossFit or people training and that sort of stuff. I have people training 5-6 days per week, and they're just in it for wellness, and they feel like crap and those sort of things, and their shoulders are fried and they're getting all these shoulder injuries. So definitely throwing in that education piece is obviously the most important part, seeing what their goals are, and making sure they're well understood of what's needed from them, and that way they can again take it upon themselves. I have a person who's in a gym, and the head gym person pushes their clients, which is great, but pushes them sign up for all these events and do all these sort of things, train outside of this. And it works when you're a highly tuned elite athlete. It doesn't work when you're 50, 60 years old and haven't worked out in the last 30 years. So sometimes, again, it takes an athlete, having to almost defend themselves to a degree. So I try and hammer that home, make sure they're well educated on that. And then, especially during those last phases and that sort of stuff, we can go into the weeds about like return to throwing programs and everything like that. There's some articles that kind of outline that. It's a bit lengthy at times. But, we do need to challenge the athlete, obviously. So it's not like, oh, they did the rehab process, we got the range of motion, great. And then as soon as they went back to throwing, they felt like shit again. I like to try and do as many things as I can to try and simulate the sport, the motion. It's not the whole session. It's probably one exercise per session where I'm integrating like some throwing motions, challenging them, trying to make it fun and engaging, but still doing the things I need to do. So getting them in the pitching position, doing some rhythmic stabilizations, having them pitch, or getting the barbell over their head, and kind of adding some perturbations with that. So it's just some things more from a psychological standpoint. I think I like to do that. Is it per se evidence-based? Probably not. I haven't really seen too much of that, but it helps people. You can tell when they leave, they feel excited about things because their brain's able to kind of link that, hey, this is close to what they previously had pain with, and we've got some sort of modified version of it, and it helped them out. So, or they weren't able to have any issues with it. So that's kind of what I like to do. I think there's some benefit to that. Again, I don't know if it's from a research standpoint, just something I kind of developed and people appreciate, but that's me. Anything from you, Brandon? Anything else?
Yeah, I'd say especially this is more so post-op throwers, but it can even be and just someone who's been shut down for a while, but definitely post-op, like labral rotator cuff, things like that. Just because they're 6 months, 8 months, 10 months out, and they've hit other markers, and they're looking good strength wise, and even like you, Jared, you put them through the bit of the ringer in the office, and they go and they throw, according to their program, or even if you throw within the office, if you have, a bullpen session or the space to kind of throw in your office, you understanding as a clinician, and also being able to then educate your patient of, it's not going to be perfect. There's going to be some soreness there. There's going to be some new adaptations. You're not going to have the same range of motion you did right off the bat. That's going to take months of throwing again. Because typically if you had a labral tear, they probably tightened you up a little bit. Think about it, that capsule was cut into. Think of all the proprioceptors that are in that capsule that were injured and now need to regrow and then be retrained. You have to, let's say they tightened you up a little bit. A lot of surgeons will kind of over tighten you a little bit, knowing that you're going to get that back in time when you go back to throwing. So they could kind of anticipate, okay, if I tighten this up a little bit more, he'll get it back when he starts throwing, versus just putting it together. Let's say they do this and then it gets stretched out again. They're going to overlap it a little bit, so it stretches out to hopefully what it was. That's me demonstrating. That's probably not what's really happening, but understanding that there's going to be, a lot of these surgeries are a year rehab, 2 years, a year and a half before that athlete starts to begin to be normal or feel normal, even though they're going back to sports sooner. So understand, as long as it's not, sharp pain or some type of intractable pain, that there might be, a day or two of soreness that they need to not rush back, and understand that, this is those tissues need to be kind of restretched and re-educated, and build up that tolerance and kind of robustness around that area.
Yeah, I think it's super important for the people to understand, and especially hopefully if it's not, but I get a couple people on their second go around with like labrum, and they're one step away from a ladder J procedure, which definitely they don't mess around with that. They're going to tighten you up. Sometimes, especially in those early phases, I'll allow some tightness. Again, especially if it's more the dislocation type. I think I have the article at hand, but what we're trying to shoot for is like about, especially once they start getting into the throwing phases, about 130 degrees of passive external rotation before they start to get in. Obviously, they're going way past that when they actually actively throw. But anything less than that, or like in that 110 to 130 range, if you're working with someone and they're just barely getting the 90 and you're saying go throw, that's probably too tight. So you want to stay within that range in order to get them to throw comfortably and get all the way back. I believe 130 is the sweet spot post-op labral repair. But that way, I believe. And then there's some research about your maximum external rotation, and the larger the difference between passive versus your maximum leads to more injury. So if you get to like 180 and you're sitting at 90 or 110, that large difference can lead to more injury. So if you're at 130, which is pretty much what we can probably push someone passively, that's probably the sweet spot for anybody out there. But again, it takes time. I'm not going to push that, week 1, week 2, week 3 and stretch out that fresh, repair. We'll let it happen over time, and then make sure right before they're ready to throw, that's when I want to make sure to get that last little check. Okay, we're good to go. And, it's going to take some time to kind of, break it in a sense. So
yeah, break it in is a good analogy.
Awesome. All right. Well, any closing remarks, any announcements there, Brandon?
We have, it's, what is it? End of July, early August. We got, 4 courses coming up in the fall. September is for cervical thoracic, which will cover a lot of what we talked about, especially in the examination and treatment part, involving the neck, T-spine, neurodynamics, even shoulder girdle. October's lumbopelvic, which is down at Jeremy's place in Glassboro. In November, we've got our extremity HVLA course, and then December we got the big spinal manipulation course. So hopefully we see some of you guys out there. We also have our mentorship program, which can be found online. Any questions or want to know more about it, please feel free to contact or reach out to me and Jeremy. We'd be more than happy to fill you in and give you a little demo about it.
Awesome. Well, thanks for listening in, everyone. It was an awesome episode, and cheers.
Cheers, guys.
Rip this one.